Hi and welcome back to the Encode. As always, I am Glenn Keating, and we wanted to start by talking today about the first steps in any patient encounter. That, of course, is being BSI and scene safety. And just as the importance of BSI over the years has increased, so too has the focus on scene safety standards. While BSI standards protect providers and patients, current scene safety standards may actually be harmful to patients while not significantly improving the safety of providers. A new post on fireengineering.com entitled EMS Wake Up Call questions the effectiveness of staging and the resulting delay in delivery of care in situations where the scene may or may not be secure. Our guest today joining us by phone is the EMS editor for Fire Engineering magazine. In addition to that, he is a registered nurse, an EMS board member for the International Association of Fire Chiefs, the EMS coordinator for Saratoga County, New York, and holds numerous other positions as well. He is also the author of this article that we are discussing today and a lover of cookies. We're pleased to welcome Mr. Mike McEvoy. Mike, how are you, sir?
Good. How are you?
Doing great. Thank you very much for joining us. And I think we'll start off. Why don't you just give us a quick overview of what you're talking about in this article and the key takeaways for our viewers and listeners.
Well, I guess the original premise of the blog post was a phone call that I received about probably a month or so ago now from a mother whose 13-year-old daughter had overdosed on heroin. And in our county system, like many other places in the country, virtually most calls where law enforcement is dispatched, the EMS agencies would stage until law enforcement arrives on the scene, primarily out of concern for their safety. And this particular instance, the husband of the woman who called me got a panic-stricken phone call at work and drove over to the residence from work, and on his way passed an ambulance that was staging several blocks from the house. And he noted when they arrived, after the police got on scene, that it was the same ambulance that he had driven by, which prompted his wife to call me a couple weeks after the incident and just ask me what was the protocol, why was it that they didn't come immediately when there was clearly a young person who was barely breathing and kind of on the brink of death. And her concern, she wasn't really angry, but she was posing a question to me, which is what I talked about in this blog post, as to what the priorities of EMS were to the people in the community, to stand by and watch out for themselves, or to run in and render aid in situations like this. And so that sort of led me to think a little bit about that, coupled with the discussion that's going on nationwide now about active shooter incidents and the propensity for EMS and variable responses. Where the Orlando shooting, there was some discussion about the preparation of people to actually be able to go in to the situation. The Aurora, Colorado shootings, the police transported a large number of people because of communication difficulties. And I think the question is repeatedly being raised as to how prepared and how willing we are on the EMS side of the house to actually go in and do things in those kinds of situations. So in a nutshell, that was the premise of the blog post. My contention is that we should really look to do away with staging, to go back to some of the situational awareness and the ability to manage conflict and the skill set that people had many years ago, where they could recognize some of the situations, deal with conflict when it occurred on scene, know when it was wise to back out, know when it was safe to go in, and not have to depend on somebody else to make those decisions for them. So that was my first premise in the blog post. And the second was that I really believe that our folks, in many cases in an active shooter situation, will choose to go in and probably should have the appropriate equipment to make those entries once the police have sort of taken out the shooter, or at least assured that it's safe for them to go in there under police accompaniment. And so that was kind of my contention.
Okay, gotcha. You mentioned situational awareness. How does one necessarily teach? How do you teach situational awareness?
Well, that's a good question. And I think that we've kind of done a disservice in education over the years in that we have this mantra that people, sort of mumble when they're doing their practical skills exam, like they hold their hands up with a pair of gloves on and say, okay, scene safe, BSI. And I think that people then walk away with the contention that, if they've done a quick check of the area and there's nobody standing over them with a knife, that things must be safe, so to say. And I think from a perspective of how we actually um, convey to people the concept of situational awareness, I'm not so sure that we're doing a great job of that in our educational programs, but we're also certainly not putting any expectation on our providers that they would continue to maintain a sense of what's happening around them when they're on calls and giving them any training as to what are the things that they need to look for and what are some of the things that potentially are going to or could become hazards to them and how they should position themselves to be ready to deal with that sort of stuff. In the past, if you go back 20, 30 years ago, a lot of that training came from the law enforcement side of the house. And I think that that's starting to, that integration or that mixture of having some of those folks come out and do that training for EMS is beginning again. But there's a real disconnect between the disciplines that has evolved over probably the last 10 or 15 years, where what we used to get collaboratively working with them and training with them, we're not really seeing so much anymore. So long answer to your short question is, I think that the kind of training that I'm talking about is training that we probably would get best from folks who are in the law enforcement side of the house.
Right. So is this necessarily um, specifically active shooter type training, or is this also training that we could use training from, say, doing things like just de-escalation of critical situations and something like that?
I think it's training that we use every single day, day in and day out, from the call where there's a stub toe to the kind of situation where, you're dealing with somebody with difficulty breathing who just so happens to have a handgun sitting on the table next to them.
So I guess my next question would be, so is it super vital that we incorporate this training early, or is this something that kind of needs to be just something learned over the years, practicing in EMS?
I think it has to be taught from the very beginning. I know if you look at the National Registry scenario-based examination that they're doing now at the paramedic level, one of the things that is a component of that is you're actually a team leader, you're running an entire call, and you have to be cognizant of things that are happening on the scene. For example, if you had a patient who you're having a discussion with about a psychiatric issue and you've convinced them to accept transport, and they say to you, I'm going to get my sweater out of the closet, we wouldn't want a student or a person who's a candidate in an exam allowing that patient to go into the closet and get anything out of it. You'd like them to have learned somewhere in their training that, oh, that's potentially not a safe action to allow to occur.
Gotcha. Very good. And then how do we justify the risk to providers versus the benefits to both the patients and providers in these types of situations?
Well, I guess that's a good question, um, and I think the answer to that is not a one size fits all approach, because there are certainly places in the United States where law enforcement could and would and does consistently arrive on scene prior to EMS. There are places where to sit and wait for law enforcement is going to involve 20 or 30 minutes of sitting and waiting until they arrive. And I think, though, if you take a broad look across the United States at how EMS providers get injured, primarily they're getting injured and killed in motor vehicle crashes, not in situations where they're interacting with a patient who then does something that causes them to get injured. Probably the second leading cause of injuries in EMS is back injuries and lifting injuries that happen to them. It's pretty uncommon to see an EMS provider get injured or killed by a patient in a fashion that you could have done something to actually have prevented that. For example, there's discussion about should the EMS providers be wearing bulletproof vests continually. And if you look back in the last year, 2 years at providers that have been shot, stabbed, even killed in the line of duty, there's very few of those instances where having such a piece of equipment on would have averted the injuries or the fatality.
So is this something the departments and really we as a country need to do a better job of keeping statistics on?
Well, I absolutely think so. And one of the things that the national EMS groups, including the International Association of Fire Chiefs, are working with the Department of Labor on right now is trying to break out EMS providers by a little bit more specific categories. So when Department of Labor is keeping injury statistics and keeping employment statistics, you could actually see the difference between an EMT and other healthcare providers, a paramedic, for example, a firefighter paramedic versus a commercial service paramedic. Right now, everybody's lumped into one broad category. It's almost impossible to determine who gets injured, who gets employed, who does anything under labor statistics by the category of EMS provider.
Gotcha. All right. And then is there any kind of research being done right now looking at these types of scenarios, whether or not staging, waiting for police coverage and for them to secure the scene is truly being beneficial, or if the numbers are showing that it's harmful?
I'm not aware of anything that is being done or has been done along those lines. I think where we got to, or how we got to where we are today, is a component of the priority dispatch systems, because virtually all of the dispatch, probably about 6 to 10 years ago, started considering scene safety as an element that needed to move between the disciplines. And so clearly we've always in law enforcement collected information about, are there weapons on scene, is there alcohol involved, is somebody still on the scene who's committed a violent act, and we convey that to our responding law enforcement officers. They suddenly decided that, hey, wait a minute, that's probably an important piece of information to incorporate in medical dispatch as well. And that's where staging got its birth, I think.
What would you recommend as just a general improvement to what our current practices are with staging?
Well, that is a very good question, and something that we're struggling with right now in my home community. We're really taking a close look at, if we don't stage people, and we're actively working in how we can kind of eliminate some of these things, like that situation that I talked about with the 13-year-old girl who overdoses, where obviously from all the information that we have, that scene is relatively safe scene for a crew to walk into without the police being there first. It's difficult, though, if you take all of the responses that we make, to figure out a way that you can adequately convey information to a responding fire department or a responding EMS crew about what potentially they might be walking into, and kind of raise their awareness when you have flags that go off that say, oh, there may possibly be weapons there. We may see something in a premise history that says this is not exactly a residence where there have been no problems in the past. In fact, we know there have been problems there in the past. So how you do that is sort of the conundrum that I'm struggling right now with as I try to work through this situation with our communications division.
For sure.
And I don't have a good answer yet.
That's all right. The last question I will ask you, because this has kind of turned into a PR, I guess, event with your department, has it not?
Yeah.
Yeah. So how do we control the damage? How do we handle PR events associated with responses like this?
Well, this is an interesting question, because in many ways our society has changed. January 1st of this year, the baby boomer generation started to turn 65 years old. And the baby boomers are a very different generation than we have ever had in society before, because they ask questions and they want answers to things. And so we're dealing with a growing population that's going to continue to grow over the next 20 years or so, until they all get into ages where we'll have the next population move in there, generation whatever. But I think that two things have happened in society. One is we certainly are living in a world that is not as safe as it was many years ago, and random acts of violence that are occurring on a routine basis are somewhat frightening. And I think that the response that we're making, the responses that we're attending to today in all sides of the house, police, fire, and EMS, are not as safe as they were in the past, and they're not as predictable as they may have been in the past. But at the same time, the demands of society, I think, are really changing, and I think a lot of that is driven by the baby boomer generation saying, we'd like to know when we call for assistance that somebody's going to come, and they're going to come quickly, and if there's risk that's involved, that they'll do their best to mitigate that risk. But essentially, they're not going to stand around the corner and wait until someone else gets there. They're going to have to find a way to mitigate that risk themselves, and get into that situation and start to deliver care. So I think that that's the conundrum, and the PR nightmare that we're facing with this, and I think we're gonna face as we move forward, until we can figure out a way to actually do what the public is asking, which is to get in there and start providing care in virtually every situation. We're going to continue to be asked that when it's obvious that either we weren't permitted to go in, or we weren't prepared to go into a situation. And I'm not sure exactly, aside from figuring out how we can work with our law enforcement colleagues to make sure that when it's necessary for us to get in there, that we have the training, we have the equipment, and the wherewithal to be able to do it safely.
Gotcha. Very good. Well, certainly a great article, sheds a lot of light on a significant issue within our current practices. You can find Mike's blog online, and as well as the article EMS Wake Up Call at fireengineering.com, or you can find out more about Mike McEvoy at mikemcavoy.com. Once again, our guest, Mike McEvoy, and we thank you so much for joining us from Saratoga County, New York.
Thank you.
Thank
it's
you.
been a pleasure.
All right. Thank you so much.